Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, I'm joined by our deputy editor Nick Bostock to talk about the latest news affecting general practice. Coming up, we're talking about the findings of the independent review into the use of physician associates in the NHS and what this means for their role in the future. We're looking at the results of the latest GP patient survey and what that tells us about how patients feel about general practice. And we're talking about what happens next for neighbourhood health as more details emerge about the government's plans for 42 sites that are set to push forward this agenda. That's all to come on this episode of Talking General Practice. So last week, the results of the long-awaited review into physician associates and anaesthesia associates was published. The independent review, which was commissioned by the government, was carried out by former NICE Chief Executive Professor Gillian Leng. So Nick, what exactly was the review looking at?
West Streeting announced this review last November, basically to try to draw a line under growing concerns about the safety of physician associates and anaesthesia associates working in the NHS, and to try and sort of map out a way forward. And this review by Professor Leng was to look at how these roles work in healthcare teams, whether they're safe, and to examine what part they can play in providing quality healthcare. In terms of what sparked all this, we probably need to go back to 2019 and the start of the 5-year contract that ran from 2019 to 2024. As a part of that multi-year deal, the government introduced the Additional Roles Reimbursement Scheme, the ARRS. And that scheme directed hundreds of millions of pounds a year in ring-fence funding, rising eventually to well over £1 billion a year, developing multidisciplinary teams in general practice by recruiting large numbers of staff other than GPs. So among the roles that was brought in was the physician associate role. There were a handful of people in these roles in general practice before 2019, but with the ARRS, this rose to more than 2,000 by the end of 2023. Bubbling under the surface, though, the chorus of dissent around physician associate roles was growing. And one of the big turning points was the case of Emily Chesterton, a 30-year-old who died in late 2022 after developing a pulmonary embolism. Emily Chesterton went to her GP practice twice, a week apart, these two visits, and she saw the same physician associate who she thought was a GP. And she died on the evening of the second visit to the practice. And a coroner later said that had Miss Chesterton been sent to hospital immediately after either of those visits to the GP practice, she would likely have survived. GPs called for new supervision rules for physician associates after that case. There was a lot of debate about public confusion about the difference between these staff and doctors. The BMA published evidence about the scale of concern among doctors about the safety of associate roles. And then the BMA and RCGP both voted last year for physician associates to be phased out of general practice. And they published guidance severely limiting the sort of scope of what they believed it's safe for these staff to do. Another part of this has been the decision to make the GMC responsible for regulating physician associates and anaesthesia associates. That began formally from the end of last year, and the BMA concern was that having the doctors regulator responsible for regulating staff who are not doctors risked adding to that public confusion and blurring the lines between doctors and non-doctors, as they have put it. So that was the background that led to the government announcing a review. It acknowledged that doctors had raised legitimate concerns around these roles, but it wanted to bring an end to a debate that it said had become increasingly toxic.
It was a pretty comprehensive document in the end that was published. What were the key findings from all of this work that Professor Leng did?
The Leng Review came up with 18 recommendations, all of which have been accepted by the government. But some of the standout points include a recommendation that physician associates should be renamed physician assistant. And that's a change intended to sort of clarify that they're not doctors, but assistants to doctors. There's also a recommendation that staff in these roles should never see undifferentiated patients and should never triage patients. The report said they should have 2 years' experience working in hospital before being allowed to work in a general practice setting. It also backed creating a defined national job description, although it didn't support the idea of a set scope of practice for physician associate roles. The Leng Review said it had found no convincing reasons to abolish the roles completely, but also that there was no case for continuing with the roles unchanged. It was also really critical of the way the roles were introduced to the NHS in the first place, and it said there was no clear vision and that this had caused confusion about the purpose of the roles and about their remits as well.
You said there that the government has accepted all the findings, and NHS England has actually written to NHS trusts and other organisations that employ PAs, including GP practices. So what does this mean in practice now?
After the government accepted the recommendations, NHS England wrote to NHS organisations to spell out immediate actions that they should take. The name change, for example, is to be implemented immediately. So these staff should be called physician assistants from now on. And NHS England highlighted how the role's remit should change too. The points about not seeing undifferentiated patients or triaging patients. In general practice, it's quite likely that most practices that have PAs already use them in this way, because not seeing undifferentiated patients was a key part of what advice from the BMA and RCGP had suggested in terms of limiting the way those roles operate. But ultimately, NHS England is going to be working through all of the review's recommendations to implement them, because as we said, they've been accepted in full by the government. NHS England also welcomed clarity on how physician assistants can be used in the health service in future, and said it was right that the review had taken place to look into legitimate concerns raised by doctors and others.
It is interesting, though, isn't it, that this is NHS England's position now, because when PAs were introduced to the ARRS, I think in year 2 of that 5-year GP contract that started in 2019, there was a set job description for PAs employed under the ARRS, and that job description specifically stated that PAs should be seeing undifferentiated patients, didn't it?
Yeah, so this is a big change from the initial NHS stance on the role for what it's now calling physician assistants. When the physician associate role was first introduced through the ARRS, the network contract DES, so that's the bit of the GP contract that governs practices' involvement in primary care networks, that said PCNs, and this is a quote, must ensure that these staff provide first point of contact care for patients presenting with undifferentiated, undiagnosed problems. So it's kind of the diametric opposite of what the Leng Review has concluded is the right idea. So it wasn't just that they could be used to see undifferentiated patients. The NHS England guidance at that time suggested that they had to be used in that way. So the recognition that this approach isn't safe and that doctors' concerns were legitimate is a massive turnaround. One thing to mention here is that although NHS England and the government are backing the recommendations from Professor Leng, not everybody is happy. The BMA says the recommendations don't go far enough. It's particularly unhappy about the failure to recommend a fixed scope of practice. BMA raised concerns about this allowing a sort of postcode lottery approach with variation in what physician assistants might be able to do in future across the country. It may also be significant that an organisation called United Medical Associate Professionals, UMAPS, that's an organisation that represents PAs and AAs, says it rejects the recommendations from the Leng Review. UMAP started legal claims earlier this year against GP practices, the RCGP and the BMA over changes to PA roles, and it now looks likely to push on with further legal claims as the Leng Review advice is implemented. And in a statement this week, it said that by immediately advising NHS employers to start implementing the Leng Review advice without any consultation period, NHS England, in its words, may be placing trusts and surgeries at risk of breaching employment law. Basically, UMAPS has suggested that it could now target GP practices, trusts and other employers for legal action over the implementation of these changes.
We know the RCGP changed its position last year on PAs, and its current stance is that the college believes there's no role for PAs in general practice. Has that changed? What has the RCGP had to say about all of this?
As for the RCGP, as you said, the college's current position is that there's no place for physician assistants in general practice. That's not what the Leng Review concluded. So as things stand, the RCGP is at odds with the review's recommendation on that front. A statement from the college last week said that it originally developed its guidance on how these roles could work in general practice, not really because it supported them, but because it recognised that these staff already existed and that advice was needed to make sure that they were deployed as safely as possible by practices. And that the college's current stance on these roles was set by a vote at its council in 2024. So the RCGP says it's now considering the Leng Review findings, but its position basically won't change unless its council votes to change it.
Something else that's worth mentioning here is that the 10-year plan, which we talked about at length on the last news podcast, that actually mentions the Leng Review. There's an interesting line there about the fact that the new way the NHS is going to work, built around neighbourhoods and neighbourhood working, means there will continue to be a focus on new mixes of skills and possibly the creation of new professions in different clinical teams. But the plan says that if this happens, the design and implementation of any new roles will learn the lessons from this review. I think it talks about how PAs were introduced with a lack of clarity about their role and their responsibilities, much like Professor Leng pointed out. And the 10-year plan says that if there are any new roles or expanded roles introduced in future, it will be made much clearer how these will work and what tasks these people can take on when they started. I think the new workforce plan, which is apparently due out later this year, it'd be really interesting to see what sort of role the government sees for PAs going forward in that. The current workforce plan, which was developed by the previous Conservative government in 2023, that envisaged a significant expansion of the use of PAs in primary care. It was aiming for 10,000 PAs working in the NHS by 2035, with much of that expansion focused on primary care and mental health. That workforce plan saw them as playing a much bigger role when regulation for PAs kicked in, because it meant that the NHS could then start looking at giving them prescribing rights. Given what we've been talking about today, will PAs still have such a big role to play in this new workforce plan? So, Nick, I guess to wrap this up, what do we think all of this means for general practice?
I think the likelihood is that we'll see a move away from physician assistant roles in general practice, despite the government statement after the Leng Review that they'll continue to play an important role in the NHS. For one thing, actually, just coming back to what you were saying a minute ago, one of the things that came out of the Leng Review was a suggestion that physician assistants could be offered the possibility of retraining as doctors. So basically, they've done 2 years of training as a physician assistant in general on top of some kind of science degree, basically. And the idea is that they could be offered a sort of fast-track route into retraining as doctors. So that could be one way of repurposing these staff who, through no fault of their own, ultimately have ended up in this situation, clearly are interested in being part of the NHS workforce and probably do have a contribution to make. We mentioned earlier the guidance put out by the BMA and RCGP around the use of physician associates over the past year. And that guidance really scaled back the role PAs could play in general practice, and it made clear the amount of supervision that they need from GPs. It wasn't official government guidance, but a lot of practices seem to have followed it because of concerns around safety. And the Leng Review has confirmed some of the key points in that BMA and RCGP guidance, in particular, as we've said, the point about not seeing undifferentiated patients. So compared with the way their role was envisaged when the ARS began, a lot has changed, and PA roles are now a lot more restricted. The maximum reimbursable amount for a PA under the ARRS is actually similar to the amount for a pharmacist, for example. So they're not cheap. And from this year, the rules on how ARS funding can be spent have changed a lot. There used to be limits on the proportion of funding that could be spent on different staff, and it used to be for non-GPs only. Now, PCNs can spend their ARS allocation on whatever staff they like from the eligible list. So if PAs can't do so much and need massive GP supervision, they may decide to spend the money on a part-time GP or on another member of the multidisciplinary team instead. There's some evidence that PAs are already being phased out too. PA numbers in general practice dropped by about 100 in the year to March 2025. And we'll have to wait a couple of months to find out, but I'd expect the next quarterly data to show another drop on top of that.
In-person learning is a vital part of keeping up to date, enabling GPs and other health professionals to learn with colleagues, ask questions of expert speakers and benefit from networking. MIMS Learning's event page gives you details of all the general practice focused learning events, which will provide you with practical take-home points for your practice, along with CPD certification. Visit mimslearning.co.uk/pages/events to find out more. So next up, we're looking at patient satisfaction with general practice. Nick, the results of this year's GP patient survey were published last week. Looking at the results as a whole across England, what did they show?
75.4% of patients who took part in the survey, and this is from something like 700,000 responses, so it's a really huge sample of patient experience of general practice in England. So 75.4% said their overall experience of their GP practice was good. And that's up from just under 74% last year. So it's a rise of about 1.5 percentage points year on year. There's been a change in methodology in this survey in recent years. So technically, you can't compare back beyond 2024. But these findings suggest that patient satisfaction with general practice is recovering after a real slump at the start of this decade, which actually coincided with a drop in overall satisfaction with the NHS. The figures also show an improvement in the proportion of patients reporting that it's easy to contact their practice by telephone, via the practice website or the NHS app. And all of that lines up with improvements that have been recorded in the ONS, the Office for National Statistics Health Insight Survey over the last year. That's something they've been running monthly, whereas the GP patient survey is an annual thing that, where the responses are recorded in a 3-month block at the beginning of each calendar year. So it's a positive result overall for general practice, ultimately.
You did a bit of a regional breakdown as well of the results. What sort of picture did you find?
Significant variation across the country, which you'd expect. That's normal, and that's what's been seen in the past. To just sort of talk about the scale of it, around 4 in 5 patients in some parts of the country say they had a good overall experience of general practice, and in other areas it's as low as 2/3. Dorset ICB and Herefordshire and Worcestershire ICB both had around 81% of patients who rated their overall experience of GP services as very or fairly good in 2025, and that's the highest levels of satisfaction recorded. But at the opposite end of the scale, just 67% of patients in Bedfordshire, Luton and Milton Keynes ICB rated their experience of GP services as either very or fairly good. One thing that's interesting about that is that Bedfordshire, Luton and Milton Keynes ICB also happens to be England's most under-doctored ICB. So it has a higher number of patients for each fully qualified GP than any other ICB area in the country. And it's hard to imagine that those two factors aren't linked. Most ICB areas saw an improvement in patient satisfaction over the past year, but not all of them. Patient satisfaction actually fell in 3 out of England's 42 ICB areas. I mean, that also shows just how much work there is to do ultimately on boosting GP numbers and on access to general practice overall.
You also looked at patient satisfaction compared with size of practice, which was really interesting. What did that show?
Yeah, so the link between practice size and patient satisfaction is something that's fairly well documented. Patients tend to be happier in smaller practices. So I had a look at how this year's patient survey results matched up with that. And it's pretty remarkable just how obvious the pattern seems to be. The average GP practice list these days, just for context, is just over 10,000 patients. And if you look at practices with fewer than 5,000 patients, so half the national average or below, and that's about 1/6 of practices in England, the average proportion of patients who rate their GP service as good in those practices is 80%. The other end of the scale, in practices with more than 25,000 patients, it's just 69%. So in between, for each 5,000 patients added to list size, basically, I looked at it in blocks of 5,000, so 0 to 5, 5 to 10, 10 to 15, and so on. And with each 5,000 block that you add to the list size, average satisfaction drops. So it's a really clear sort of line on the graph. You can look at that graph on our website, GPonline.com. So it's really clear, smaller practices are more popular, but average list size is growing all the time as more and more, often small practices close.
That's been a real trend, hasn't it, over the past few years, is the average list size getting bigger. And certainly with the 10-year plan, it seems like the government is very keen on at-scale provision, as we talked about a couple of weeks ago. But these findings suggest that patients really do prefer smaller practices, don't they? The government talks about bringing back the family doctor, and these results suggest smaller practices should be a part of that, don't they?
The language in the 10-year plan, as we talked about on the last news podcast, really seems to pin the blame for pressure on general practice on small practices, and to suggest that more GP services at scale is the solution. I mean, just to recap on that, what the plan said is that the status quo of small independent practices is struggling to deal with 21st century levels of population ageing and rising need. And it said that without economies of scale, many dedicated GPs are finding it difficult to cope with rising workloads. And then it proposed 2 new large-scale contracts as potential alternatives to the existing GP contract. The BMA is really clear that the 10-year plan could threaten the viability of the smaller practice model, and it warns the government not to put practices like this, which are clearly popular with patients, at risk. The RCGP also said it was important that the personalised experience of care that smaller practices can offer, which patients value, isn't lost in the move to delivering GP services at scale. And that there's another point to mention here as well. It's not just that these smaller practices are more popular, they're also associated with increased continuity of care. And that's something that's been shown to save lives. The RCGP says it's not impossible to operate at scale and deliver continuity if practices organise their triaging and appointments in the right way. But the point is, small practices are popular and often very effective. And they could be the key to doing, like you mentioned, what the government says it wants to do, bring back the family doctor. So looking after those practices in the context of changes to the health service is really key.
We talked at length on the last news podcast about the 10-year plan, and last week I was also speaking to Dr. Duncan Gooch, the chair of the NHS Confederation's Primary Care Network, about what the plan could mean for general practice. But we thought it would be a good idea to catch up on what's been happening over the last couple of weeks around this, didn't we, Nick?
Yeah, so you found out a bit more about the 42 sites that the government said are going to push forwards with creating this neighbourhood NHS. What do we know about those sites now?
Yeah, so NHS England has put a call out for areas to apply to become one of these sites. The deadline for that application is very soon, 8th of August. Sites are going to have to be co-sponsored by the Integrated Care Board, the ICB, and the local authority. And I think what the government and NHS England are looking at, they're basically looking for one in every ICB area. And these sites are going to be tasked with focusing on adults with multiple long-term conditions and looking at how they can better design care to meet the needs of those people in the context of working as a neighbourhood. I think this is probably just a starting point though, and the idea will be to expand this work to cover other cohorts as time goes on. So this is called the National Neighbourhood Health Implementation Programme, or the NNHIP. So we've got a new NHS acronym to remember as there. And as well as being co-sponsored by the ICB and local authority, the sites that will be successful in this application process needs to have all of the local partners, so all the PCNs, voluntary organisations, community services, mental health, the hospital, everyone needs to be involved and signed up to this. I think they actually might have to actually have physical signatures from all of the providers on the application. The successful sites will probably have some background already in neighbourhood working or some examples of working together to tackle local issues. And the government and NHS England have said that they are going to prioritise deprived areas to be selected for this programme because they say these areas are likely to see the biggest impact from neighbourhood working. The sites have to be geographically aligned around sensible neighbourhoods. And for example, they've got a big area in the middle of their patch that isn't part of one of the PCNs. That's not going to be chosen, basically. I think the 42 sites are going to be announced in early September, I believe, but a recent webinar on all of this, NHS England said that this would be the first wave. So it sounds like this is going to be an ongoing programme with more sites selected and added to it as time goes on. The 42 sites, if they're successful, they're going to get access to a coach to help them embed change. They'll go to workshops where they can learn from what each other is doing. They'll get some support with implementation and guidance on how to assess whether what they're doing is working. Each site will also have to have a clinical and managerial lead. But what they're not going to get, though, is any extra money to do this. Everything to do with this, including the funding for those coaches and those clinical and managerial lead roles, will all have to come from existing funding within the Integrated Care Board.
So, quick pop quiz, Emma. You mentioned PCNs that have an area in the middle of their patch that isn't part of the PCN. What is one of those called?
Well, according to Dr. Claire Fuller, who is the NHS England's medical director for primary care, that's a donut PCN.
It is indeed. Very good. These aren't pilot sites, are they? That's not what NHS England, the government's calling them.
No, exactly. And that's why there's not separate funding for this. That webinar was really clear that these aren't pilots. What they're calling this is a large-scale change programme, which is focused on the systematic spread of knowledge. So it's not about testing new ideas, but it's about spreading approaches that are already working across the country. So they're not going to give these areas loads of extra money because they want this to be replicable everywhere. They want systems to implement these changes themselves, and then these 42 sites sort of become a catalyst for it to spread across the rest of the area. So that's why they're looking for a site from each ICB area. Basically, the ultimate goal is to spread this across the whole country by the end of the 10-year plan. I think it will be really interesting to see which sites are selected for this. I'm sure they will choose sites that can make a success of this. There probably will be places already doing a lot of this work already. They certainly won't be places that are starting from scratch, I wouldn't have thought. It'll be also really interesting to see if any of the sites that are selected have hospitals very much at the forefront of leading on it, or whether they're all going to be much more primary care led and maybe led by at-scale primary care organisations. I would imagine that some of these sites could potentially be some of the first to look at those new neighbourhood contracts that you mentioned earlier, Nick. They're going to be available from next April. These first sites might also well end up being the areas where the government really tries to push forward on some of the more significant changes it's talking about in the 10-year plan, such as these year of care payments, which they are going to need to trial somewhere before they get rolled out more widely. For people who don't know, those payments are where geographical areas will get a budget for a patient's care over the whole year rather than a fee for service. And the 10-year plan talks about the fact that these payments could include all primary care funding, community health, mental health, outpatient care and emergency care funding all bundled up into one payment. The government says it will apparently be working on this during 2026-27, and the plan suggests that these year of care payments could be a real key driver to helping shift services out of hospitals and into the community. So that's kind of what's going on with those sites. But Nick, we've also heard a bit more from the BMA GP committee over the last couple of weeks about what they think about all of this, haven't we?
Yeah, so there's some tough language from the BMA GP committee in its response to the 10-year plan. The committee is clearly concerned about what the 10-year plan means for general practice and for the substantive new contract that the government has said it's prepared to negotiate with the profession during the current Parliament. BMA England GP committee chair Dr. Katie Bramall said last week that she was really struggling to see how the 10-year plan could deliver a general practice fit for 2035 at the same time as retaining what's made it special since the NHS was founded in 1948. And she questioned whether continuity of care could be balanced with general practice working at scale. We touched on that earlier, smaller practices associated with continuity of care. And she said that the large-scale contracts that are billed as an alternative to the current GP partnership model suggested a vision of massive super practices that diminishes traditional cradle-to-grave general practice. I think crucially, as we touched on a fortnight ago, Dr. Bramall said that the 10-year plan had been published with very little input from anyone who does the day job. That's her quote. She's really clear that there's no evidence for general practice at scale, but loads of evidence to support the small practice model, which comes back to the discussion about patient satisfaction again. And she also said that GPs wouldn't hold back if they don't like the way that this plan plays out. She said that GPs see 1.5 million voters a day and are prepared to tell them exactly what they think. And she said that could make or break this government at the ballot box. So basically, just a few months after reaching the first negotiated contract deal in years for general practice, there's a potential gulf growing here between GP leaders and the government. So there's a lot of work to be done to bridge that divide.
I think it's certainly going to make contract negotiations tricky. You can see there might be some difficult conversations coming up between both sides there after all of this. There's actually quite a lot of uncertainty out there about all of this, isn't there, at the minute? I mean, I think we talked about this, didn't we, last time, about the fact there's just not enough detail in there to really see how this is all going to shape up in the longer term. And I've been speaking to lots of people about the plan over the past few weeks, and nobody's really clear about what it's all ultimately going to mean. I mean, some people seem to think that the single neighbourhood contract will effectively replace PCNs, but other people I've spoken to said that you can do all of this whole vision of neighbourhood health, which the government has, you can do it all with the current contracts that exist, namely the GMS or PMS contract and the PCN DES. And actually, in fact, NHS England medical director, Dr. Claire Fuller, who we mentioned earlier, she actually told that webinar that neighbourhood working isn't about giving up GMS and PCN contracts. It's about building something on top of that. Obviously, one of the other things I think there might be big question marks around is whether PCNs are going to have to become more formal companies now, particularly if they're taking on more work or running new services to sort of manage the financial risk GP partners would be exposed to if they're not companies. I mean, we know a lot of PCNs have already taken that step and incorporated. But, then I spoke to someone who works with a lot of PCNs recently, and they told me that many networks have just put plans around incorporating on hold because they don't really know what these new contracts will look like, how they will impact on the existing structure, what they really mean for PCNs, and why would you spend money on legal fees when it's not clear whether that organisational structure would work in the end. I think a couple of things that do stand out for me from some of the conversations I've been having is that I think smaller PCNs could be in a bit of trouble, those under 30,000 patients, unless there is a really legitimate reason for them being that small, such as if they're in a rural area. Basically, they might not really fit into this new structure. And I think that there's a general feeling that areas will have to cover at least that 30,000 footprint, really.
Bite-sized PCNs as well as donuts that are at risk.
There's potentially lots of opportunities and risks for practices in all of this, aren't there? But I think practices are really going to have to get involved with what's going on. People I've been speaking to have said practices have to engage with this. They have to be at the table to help shape what happens in their local area. Otherwise, they could find they miss out on some of the potential benefits of all of this, or even worse, that they are really sidelined, which could have really big consequences for, their financial viability going forwards. Well, that's it for this week. Thanks to Nick, and thanks so much for listening. I'll be back next week when I'm speaking to GP Dr. Andy Hilton, who's a partner in Sheffield and Chief Executive of Primary Care Sheffield, a not-for-profit company set up by GPs in the city, which was mentioned in the government's 10-year health plan. I'm talking to him about what Primary Care Sheffield does and how what it does improves health for people in the city. So do join me then. In the meantime, don't forget you can keep up to date with all the latest news and access lots of other resources on our website at GPonline.com.